توكل على الله ولا okay. It's my pleasure today to present my colleague Dr. Intisar Riyami. She's a specialist in pharmacogenetics, clinical pharmacist working in Sultan Qaboos University. She was graduated from Oman Medical College and she finished her master degree in Sultan Qaboos University. She received her training in Oman, then she received additional training in both Canada and UK in Sick Kids Hospital and Evelina Hospital in London. And now she is pursuing her PhD degree in Sultan Qaboos University, and she will speak with us today about a retrospective and prospective evaluation about the pharmacogenetics of tacrolimus in kidney transplant patients. So the floor is yours, Dr. Intisar, and we, inshallah, will enjoy the presentation.
Inshallah. Shukran, Dr. Rami. Is my voice clear?
Yeah, clear.
Yes. Thank you. I want to first thank you to thank the Oman Society of Nephrology and Transplant for allowing me to present my PhD proposal. Inshallah, I'm in my first year in the Pharmacology and Clinical Pharmacy Department in Sultan Qaboos University, pursuing my PhD. And my topic today would be about the pharmacogenetics of tacrolimus in Omani kidney transplant patients, which would be a retrospective and prospective evaluation. So inshallah, today I'll present it to you and for your comments, inshallah. Oh, it's not moving. 1 second. كان أول يتحرك الحين صارت مشكلة.
مفيش مشكلة، خدي وقتك خالص يا دكتور انتصار.
ما تشوف البرزنتيشن يتحرك؟
لا ما يتحرك.
أيوه حتى أنا عندي. Let's try this. Okay. I will briefly go through those headings, inshallah. So as you all know, I know that you're all nephrologists, so just a quick about kidney transplantation. It's a treatment of choice for end-stage renal disease, and compared to maintenance dialysis, it improves the quality of life and reduces mortality risk for most patients. Kidney transplantation would require complex immunosuppressive regimens, and patients who are post-kidney transplant are susceptible to infections, malignancy, and nephrotoxicity, which then would require close follow-up of those patients. And as you all know, immunosuppression is tailored to the regimen, to the patient's risk profile, and it includes induction and maintenance therapy. It has an interleukin, for the induction therapy, it has interleukin-2 receptor antagonists such as basiliximab, or lymphocyte depleting agents such as antithymocyte immunoglobulin. And for the maintenance, usually it's a combination of immunosuppressant medications, including calcineurin inhibitors such as tacrolimus or cyclosporine, and anti-proliferative agents such as mycophenolate mofetil, for example, with or without corticosteroids, although most of the patients are on corticosteroids. And the aim of this is to prevent rejection and maintain graft function. So as per the literature, calcineurin inhibitors are the basis of immunosuppressant for renal transplant recipients, and it's the first line to prevent organ rejection. And as per the KDIGO recommendation, tacrolimus instead of cyclosporine is the first line used for post-renal transplant. Coming to tacrolimus, it's an immunosuppressant medication, and it has many indications. It could prevent organ rejection in transplant recipients, such as kidney, heart, or liver. It could be also used in prevention and treatment of graft versus host disease in post-bone marrow transplant. It is used as an immunosuppressant in rheumatoid arthritis, myasthenia gravis, Crohn's disease, and others. So what is the mechanism of action of tacrolimus, also known as FK506? When FK enters the cells, it binds with the FK binding protein. And this complex will inhibit calcineurin phosphatase. What will calcineurin phosphatase do? It actually it activates the nuclear factor activating T cell by dephosphorylation. And this activated NFAT enters the nucleus and transcribes the interleukin, which then leads to T cell activation. Hence, when we inhibit calcineurin phosphatase, we downregulate the immune response. The dosing as per the Royal Hospital protocol of adult kidney transplant immunosuppression is 0.05 to 0.075 milligram per kg per dose, given orally twice daily. And usually the immediate release is used post-transplantation. It is given 2 days prior to transplant and then immediately post-operative. Although its effectiveness, but it also has some side effects. So I'll quickly go over the most common ones, such as hypertension, headaches and tremors, post-transplant diabetes mellitus or PTDM, hyperkalemia, hyperlipidemia, hypomagnesemia, GI upsets, UTI, infections, acute renal failure, and nephrotoxicity. So coming to the pharmacokinetics of tacrolimus, tacrolimus is metabolized in the liver by the CYP cytochrome P450 family, mainly the CYP3A5 and 3A4. And the activity and expression of both CYPs differ from patient to patient, which altering the immunosuppressive effect of tacrolimus. Another important role in metabolism is the P-glycoprotein encoded by the ABCB1. It acts as a pump at the cellular level, which it effluxes the medication outside the cell and controls the plasma level of tacrolimus. So treatment with tacrolimus has drawbacks. One of the drawbacks is it is a narrow therapeutic index medication and requires rigorous monitoring. And second, it has significant inter-individual variability in its pharmacokinetics, which poses challenges in monitoring and dosage adjustment of tacrolimus. Hence, there's therapeutic drug monitoring, in which a 12-hour trough tacrolimus concentration is taken. And the sampling usually is taken after it reaches the steady state, which is 4 to 5 elimination half-lives, which is translated to about 5 to 6 doses. And as you can see, the targeted trough level or the desired trough level concentration differs at different months post-transplant. So the first month post-transplant, usually the desired level is 10 to 12 nanogram per ml, and then it gets lower as time passes by post-transplant. And these levels are as per the Royal Hospital protocol. Factors that are said to affect tacrolimus pharmacokinetics are known to be age. For example, in elderly, they have reduced clearance, drug-drug interactions such as CYP inhibitors and inducers, pregnancy, GI parameters such as diarrhea and food intake, and then 20 to 95% of the variability in drug effects is known to be by genetics. Hence, we need to see the relation of pharmacogenetics to pharmacokinetics and pharmacodynamics of tacrolimus. So here we have important genes, such as CYP3A5, genes in ABCB1, CYP3A4, and others. And when we have variations in those genes, then it translates over the pharmacokinetic, which is the TDM. The TDM, we either have normal levels or we have overexposure or underexposure. When we have overexposure, it also relates to the pharmacodynamics of the medication, which is increased toxicity risk, while underexposure would have increased rejection risk. Hence, the CPIC, which is the Clinical Pharmacogenetics Implementation Consortium, has done dosing recommendation for tacrolimus based on a CYP3A5 phenotype. So say CYP3A5 phenotype has an extensive metabolizer or an intermediate metabolizer, then the implication of for tacrolimus or the expected level would be low dose adjusted trough concentrations for both extensive and intermediate. And hence the recommendation would be starting dose 1.5 to 2 times higher than the initial starting dose. And those recommendations are strong by the CPIC. While for poor metabolizers, we expect to have higher to normal dose adjusted trough concentration. And the recommendation is to initiate therapy with standard recommended dose. And the classification is also strong. And there are currently more than 80 hospitals and institutes and laboratories who implement the CPIC genotype-based dosing for tacrolimus guidelines around the world. There are different also literature about the genotype-guided dosing, and there's this paper that shows that there improved initial dosing accuracy of tacrolimus when using genotype-guided dosing, and reduced number of medication adjustments, which is ideal. Another paper suggests that it has improved therapeutic range achievement and improved delayed graft function. And then also another paper suggests that CYP3A5 genotyping is a new approach to detecting tacrolimus dose requirement. And it's a predictive index for the tacrolimus treatment selection in kidney recipients. Hence, for us to start implementing genotype-guided dosing, we really need to know the frequency of the CYP3A5 alleles in different ethnic groups. Of course, we need to know for all the genes, different alleles, but this is an example of CYP3A5. So as you can see here, the Africans have about 56% of the variant star 1. While the Caucasians have 7.8% of the variant CYP3A5 star 1, and the Middle Eastern has 10.5% of the star 1 variant CYP3A5. So there are different frequencies and different ethnicities. And although the CPIC has referenced the Middle Eastern, they did not mention exactly which countries they specified. And we know that the Middle Eastern are genetically heterogeneous. Hence, we cannot really apply it to Oman. And there are no studies currently that show the Oman CYP3A5 different alleles frequencies in Oman. We come to kidney transplant in Oman. The number of patients on dialysis as per 2019 is about 2,500. And CKD is the sixth main cause of death in Oman as per the WHO. And the kidney transplant has started in collaboration with Oxford University in 1986. And the first transplant that was done in the Royal Hospital was in 1988. And currently there are over 3,000 patients with a kidney graft. And there was a clinical observation by this physician that tacrolimus therapy varies among patients, which delays target blood levels and causing complications. Hence, I decided to do a pilot study on 30 patients just to see the TDM that we get from those 30 patients. So collecting 5 consecutive TDMs, C01, C02, C03, C04, and 5. And you can see by C05, only 27% has achieved target levels, the one in brown color. And you can see many patients, and the majority of patients have low levels throughout C01 to C05. And we know by now that low C0 means higher risk of rejection. And we also know that higher risk of high C0 means higher risk of complications and side effects. And we actually have both high levels and low levels, and their the lesser amount is achieved levels. Hence, we come to my research aim. The study aims to understand the pharmacogenetics of tacrolimus, pharmacokinetics in post-renal transplant patients to optimize dosing strategies. And we know that the current dosing method of tacrolimus is for renal transplant patients relies mainly as a starting dose on weight and then followed up by TDM. And there is significant variability in response to tacrolimus, leading to acute rejection, graft loss, delayed graft function, post-transplant diabetes mellitus, nephrotoxicity, neurotoxicity, and other side effects. And the factors which contribute to tacrolimus inter-individual variability among Omani patients is unknown, but there is prior research that suggests that there is strong genetic contribution to tacrolimus response. Hence, and genetic factors among Omani and Middle Eastern population is not fully investigated. So it brings us to the main objective, which is identify the genetic variants associated with tacrolimus pharmacokinetics, pharmacodynamics, and toxicity, and to optimize therapeutic outcomes among Omani kidney transplant patients. My secondary objectives are to determine the prevalence of these variants, to validate findings in an independent cohort using targeted genotyping of significant variants. We want to develop a genotype-guided dosing protocol and evaluate the transplant outcome and safety of this genotype-guided dosing protocol. And then we also want to identify non-genetic factors that contribute to variations in tacrolimus pharmacokinetics. So the study will be a longitudinal single-center study, which will be conducted in the Royal Hospital. And an ethical approval was granted by the MOH Research Center. So my study would be over 3 phases, inshallah. So the first phase would be investigational cohort. So we are taking 100 Omani patients in which we'll do whole exome sequencing. And with gene prioritization, we will get, inshallah, genetic variants. And those genetic variants will be validated in phase 2, in which we will genotype significant variants from phase 1, and we will validate and finalize dosing protocol according to significant variants. And then phase 3, it would be a prospective study in which we'll have genotype-guided dosing. We will genotype patients who are going to be transplanted prior to transplant, and we will determine the appropriate dose for them, and then we will assess the outcomes. Coming to details, so phase 1 would be a retrospective study, and the setting will be the Royal Hospital, in which we'll have 100 post-transplant patients who are randomly selected from transplant clinics. We will include all Omani minimum 6 months post-transplant patients on tacrolimus. We will exclude patients who have no data recorded in the first month post-transplant, and this is usually for patients who are transplanted abroad and come late to the clinic, and patients who have started tacrolimus after first 3 months post-transplant. We'll access the data using a Shifa to extract data on demographics, tacrolimus level, clinical outcomes, and adverse events. And variant identification would be using whole exome sequencing. This is how we maintain the sample size calculation using data. So our main outcome variable was tacrolimus trough level. And we've seen that patients in different studies, that patients who are CYP3A5 expressors had lower tacrolimus trough concentration than non-expressors by an estimate of 10 to 42% in different ethnicities. Hence, the total sample size required was 34 patients, but to add to it 20%, we will get 41 to 60 patients. But we decided to include 100 patients to capture rare variants and variants with small or minor allele frequencies. So for gene filtering and prioritization, so this was, we got this from the literature. For the pharmacokinetics, we will choose those genes such as CYP3A5, 3A4, POR, ABCB1, and IL-10. And we will measure TDM, which is the trough level, C0 trough level, and C0 or trough level adjusted to dose. We will also try to check the time in therapeutic using the Rosendahl methodology, and time to therapeutic level. So when the patient reach their therapeutic levels. And for the pharmacodynamics, we'll mainly check the ABCB1, and we'll measure acute rejection, graft loss, delayed graft function. And for post-transplant diabetes mellitus and other toxicities, we'll check CYP3A5, ABCB1, and CRTC2. And we'll measure those side effects listed. And this is as per the literature. The variants that are known variants in the literature are those that are shown in the screen, but we might find different variants that are related to the Omani population. Phase 2, in which it's a validation study, it will also be retrospective, and the sample size will be determined depending on effect size from phase 1, and they will be an independent cohort. Data collection would be similar to phase 1. We will conduct targeted genotyping of the most significant variants that were identified in phase 1, and we'll validate the association between identified variants and tacrolimus pharmacokinetic, pharmacodynamic, and toxicity. And the outcome, we would like to establish clinical significance of the validated variants and develop tacrolimus dosing protocol based on validated variants, so genotype-guided dosing. For phase 3, it will be a single-arm prospective study, genotype-guided dosing, in which it will be done on patients who are going to be transplanted in Oman or early post-transplant patients if they are transplanted abroad. The intervention would be adjust tacrolimus dosing based on phase 2 outcome, and we will follow them up for 6 months. We would like to get time to achieve target therapeutic level, incidence of adverse events, rejection incidence, clinical utility of genotype-guided dosing of tacrolimus in post-kidney transplant Omani patients. So those are going to be our statistical methods, and we'll use them whenever applicable. So the expected outcomes is identification of key genetic variants influencing tacrolimus metabolism, improved dosing strategies leading to faster target level achievement, reduce rejection rates and adverse effects, and extend our findings to different centers in Oman. In conclusion, we know that there is a critical gap in tacrolimus therapy in Oman. This could be due to genetic variations, and we believe the project outcome could build a dosing protocol involving genetics, which will improve renal transplant management and patient outcomes. And the result will guide future personalized medicine approaches in the different centers in Oman. This is my study plan throughout the 4 years, inshallah. And I'd like to acknowledge my supervisors from SKU is Dr. Yusuf Sulaimani, and from the Royal Hospital, Dr. Isa Salmi, and the thesis committee, and the pharmacology and clinical pharmacy department. Thank you very much, and please give me your comments and any questions. Thank you.